Thank you very much, Dr. Subhash Chandra, and I must thank Dr. K.K. Agarwal for inviting me for this rather technical lecture. And I think it's a challenge to speak on a very technical subject with people who are, not cardiologists. And anyway, I'll try my best, and maybe you can judge my teaching by, observing and give me marks out of 10 after this. So what I'm going to take you,
11 out of 10, being a wonderful teacher.
I'll be talking about the drug-eluting stents. Where are we heading? And is India ready to take this challenge? Well, we all know that the best is to prevent heart disease, not to have coronary artery blocks. And we have been having talks in the morning on prevention, how to treat diabetes. But then in spite of all these things, a large number of patients continue to have angina, myocardial infarctions, unstable angina. In fact, they are on the increase. And these patients have to be handled medically, intervention or surgery. Patients who come for angioplasty, which is a procedure in which we open the arteries without surgery by clearing the blocks and putting in stents, are increasing. And because this procedure is much more predictable and has got very low mortality, 24 to 36 hours in the hospital, that is the reason it is catching on. Now, the problems of stents, Dr. Subhash Chandra very lucidly elucidated that we had the bare metal stents till 2002, which were doing a job much better than balloon angioplasty, but had a problem of recurrence in at least 20 to 25% of cases. And that was a big problem because treating in-stent recurrence was very difficult and the long-term results were not good. And that is the reason people and scientists kept on working and came the drug-eluting stent. The basic idea of drug-eluting stent being that you deploy the stent, has some drug in it which will reduce the healing process and prevent recurrence. And the first generation drug-eluting stents had two kinds of drugs, the eluting stent, very popularly known as Cypher, and paclitaxel-eluting stent, very popularly known as the TAX. Both of them showed that they work by reducing the chance of patient back with a reblockage. But at the same time, there were some problems associated with it, which came to fore in September 2006 when Dr. Kiminiji showed in a large analysis of the data that these stents, when you compare with bare metal stents, could be dangerous. They could produce problems even years after putting them in because of clot formation in the coronary arteries, because healing hasn't occurred completely and the metal is still exposed. And all kinds of indications, elective indications, off-label indications, there was this problem, which was seen at least in up to 0.5 to 0.6% of patients undergoing angioplasty, which is a big number, but if you see, millions of stents being put in, 0.6, a large number of people. So we started looking for some new generation drug-eluting stent, and we wanted to get an ideal drug-eluting stent which would work. There will be no recurrence, but at the same time will not have clot formation later. And also we should be giving them lifelong 2 antiplatelet drugs which can produce. So one of the first group of stents which came is today very popular, called the Xience V stent. And this showed that this was better than the existing stent in a number of trials. As you can see, this is compared with the old first generation stent, Taxus, and you can see that cardiac death or myocardial infarction rates were clearly lower. And the stent thrombosis, which is one of the dreaded complications, was again significantly lower with this new generation stent, which had a polymer, but it was a safer polymer, and the stent design was much better. It was easy to put in. But there are patients who are diabetics in which it was seen that this particular stent was not better than the existing paclitaxel-eluting stent. what is going to be the best. At present, we are doing a big study called the Tuxedo India study, in which we are comparing two different stents and trying to show to the world which stent is better or whether they are equivalent. Then the new generation stent we talked about still has a polymer inside. Polymer is a chemical which is kept on the stent so that the drug which is embedded in the polymer can be predictably released over days to weeks. So all these stents had a polymer, and it was the belief of some of the cardiovascular pathologists that if the polymer remains there forever, any chemical can produce inflammation, and any inflammation occurring even years after that can produce clot formation there. So that is the reason we have been marching towards stents which have no polymer. These are the polymer-related issues: inflammation, fibrin deposition, and some of the patients, like one of our patients which we reported in the journal, 8 months after implantation there was a big aneurysm, and that again is because of inflammation. So concept came that let us have a polymer, but that polymer should slowly disappear over a period of 3 months to 4 months. Drug has disappeared, polymer has disappeared, and you are left with just a bare metal stent, which would be safe. And one of the first stents of this design was the CoStar stent, and I was fortunate to be one of the first lead investigators of this, and we showed that this concept works. That means a stent with a chemical which dissolves over a period of 3 to 4 months, and the drug also goes away. And then came a better stent called the biometric stent, in which it was shown that the polymer gets away, and the results are very good. A large study was done which showed that in terms of efficacy, it was equivalent to the first generation stent Cypher, which was the most extensively used stent till very recently. And when the long-term follow-up was done of this stent with a polymer which gets out of the body, it was seen that tendency was that it may be better. Then it was thought, can we have a stent which will elute drug but without a polymer? And these were the stents which we worked upon. And one of the stents, called the Yukon stent, the surface is simplified. That means the surface is made rough, and there are some grooves in it, and you put it on this, and this we used to coat in the cath lab itself, and coated stent, and the drug is released in a period of 8 to 10 days, no polymer, and it was seen that this particular stent had a healing process which was acceptable. And when a number of stents were compared, the older generation stents, was seen that this stent without a polymer was doing very well, whereas the other stent polymer, the healing kept on happening up to 2 years. That means the reduction in the lumen kept on happening, but with this polymer-less stent, this was not the rule. But then a concept came, can't we have a stent where you put in the stent with a polymer and a drug? The drug goes away in, say, 1 month, the polymer goes away in 2 months, and the stent also goes away, so that you are left with a normal vessel, and that's called the bioabsorbable drug-eluting stent. Something like this, so everything disappears. Why? What is the importance of this? It will leave no permanent metallic implant. If there is no metallic implant, there is no polymer, there will be no stimulus for inflammation. So long-term 2-drug therapy will not be required, and the vessel will be restored to a normal vessel without any metal, without anything. And this will be compatible with CT, MRI, and future interventions like bypass surgery if it is required. And if you are put in long stents, it becomes difficult for the surgeon to locate the artery. But if the stent disappears completely, this also is possible. And a number of products were used. The product which seems to be the most successful one is the bioabsorbable vascular scaffold, in which the drug is everolimus, the polymer is polylactic acid, and the stent is also made of one of the types of polylactic acid, which disappears within 1 year. And a number of studies of 2 cohorts have shown that they work. The first cohort had some problems, and the second cohort is much better. The other very beautiful thing which was seen is that after absorption of the stent, the vessel was absolutely normal. You inject acetylcholine, it reacts normally. But if you have other stents with polymers and other things, it doesn't. It behaves paradoxically, that means the vessel motion of the vessel is different. And the second cohort has clearly shown that the limitations of the first bioabsorbable stents had been, solved. The stent was more stiff, and at the end of 2 years, there was nothing left there, and at the same time, the vessel had not shrunken. This study has been extended to called Absorb Extend in 1,000 patients with 100. Our site is also one of the sites, and we have contributed about 22 patients. And as you can see, India has contributed about 40 patients to this particular study, indicating that we are marching very well ahead and we are at par with other countries in using, in experimenting, and giving the results of such stents. Other drug-eluting stents which have certain characteristics are being developed, magnesium stents, Reva stent. But what is the future? Are we ready to receive? I think one of the new stents has come is called the Yukon Choice stent, which is the same stent on which there are grooves and which is modified. A small amount of polymer is attached, and the drug is there, so that the drug gets released over a period of, say, 2 to 3 weeks. And this technology has been brought to India. The stent being manufactured in Dehradun, and the technology has been proven to work in a number of studies all over the world. And this unique stent, and these are the studies in which this particular stent called Yukon Choice stent has been compared with first generation and second generation drug-eluting stents, and it has shown that in terms of efficacy it is absolutely equivalent. That means there is very little healing, and as you can see, the death myocardial infarction rates of 2 years are very low, and they are equivalent to the first generation, second generation stents. But what is important is the thrombosis, the clotting of the stent is significantly lower, and the need for another procedure is extremely low. In acute heart attacks, acute myocardial infarction, deploying this kind of stent is better than the usual drug-eluting stent. The need for another procedure is much lower, and the meta-analysis has clearly shown that if you have stents where the polymer goes away, as compared to the stents where the polymer stays, the efficacy is, but the definite stent thrombosis is 50% lower, indicating that this kind of stent is very effective, at the same time very, very safe. So what is my conclusion and take-home message? Are we ready to receive these drug-eluting stents? The newer drug-eluting stents are evolving rapidly. Safety and efficacy is the main issue. Most stents used by every intervention cardiologist these days are newer generation stents. We have moved away from the first generation stents. Indian investigators in all these studies on the forefront, so there is no problem. We are as good as anybody. Bioabsorbable polymer drug-eluting stents like the Yukon Choice or the stent used in the LEADER study, and the bioabsorbable vascular scaffold, the stent also disappear, is the way to go. The future of drug-eluting stent is already here, and we are all using these products which are very safe, very predictable, and are going to last for years together without any complications. Thank you very much.